Dr. Matthew Plow is an associate professor of nursing at the Francis Payne Bolton School of Nursing at Case Western Reserve University, where his research is focused on developing, testing, and optimizing remotely tailored technology-based self-management, rehabilitation, and wellness interventions among people with disabling conditions. And Dr. Plow has a specific focus on developing and testing biobehavioral models of fatigue among people with MS. Dr. Anna Kratz is a professor of physical medicine and rehabilitation at the University of Michigan Medical School, where her research is focused on the characteristics and mechanisms of common symptoms like pain, fatigue, cognitive dysfunction, and functional outcomes in those with chronic clinical conditions. Dr. Plow and Dr. Kratz both presented at the CMSC annual meeting on the topic of MS-related fatigue. Fatigue is one of the most common MS symptoms, and it's one of those symptoms that can get in the way of fully engaging with virtually every aspect of life. Now, historically, clinicians tried to manage MS-related fatigue by writing a single prescription for a stimulant, while both Dr. Plow and Dr. Kratz are pioneers in moving away from a purely pharmaceutical-first approach, focusing instead on multimodal behavioral and self-management strategies. Dr. Kratz, the combo MS trial was a massive step forward in comparative effectiveness research, looking at telephone-based CBT, modafinil, and a combination of both. What did the trial reveal about the synergy between behavioral therapy and pharmacological approaches?
Well, the main finding is that you can have either a behavioral intervention like CBT for fatigue, or modafinil, or some other stimulant like it, or a combination of both, and they're all going to be pretty much equally effective and, importantly, clinically significantly effective. So it's going to any three of these kinds of treatments, approaches, will have a major impact on fatigue for most people with MS and fatigue.
Dr. Plow, from a behavioral and rehabilitation perspective, how does reducing fatigue via cognitive strategies or medication translate into a patient actually adopting a sustainable long-term physical activity routine?
I'll focus on the self-management aspect of it. I think that, you have to think about trial and error process, what works for the individual, and prioritizing the limited energy that you may have throughout the day. So thinking about what is meaningful in your life and what is important to you, and prioritizing those things and figuring out ways how to get those things done, but also prioritizing those things that are meaningful to you. And of course, also engaging in physical activity and exercise is really important. And trying to break that disabling cycle of inactivity, fatigue, the more deconditioning. So thinking about subtle ways to slowly improve your physical activity throughout the day, even if it's just taking an extra amount of steps per day, even if it's 10, 12 steps per day, and increasing that over time, a slow way to progress throughout the day in your exercise and your physical activity.
I believe both of your labs have utilized ecological momentary assessment, EMA, which is collecting real-time data from patients in their natural environments rather than relying on standard retrospective questionnaires in a clinic. Dr. Kratz, your EMA data has shown that fatigue and pain vary dramatically within and across days, often increasing significantly toward evening with different patterns based on sex and age. How should this real-world daily variability impact how clinicians actually assess fatigue during that standard 25-minute office visit?
Yeah, I mean, this is really tough. Patients tend to really dislike those assessments where they ask, what's your fatigue over the last month or 2 weeks or what have you, because their experience of fatigue is highly variable, both within a day, like you were saying, maybe okay in the morning and pretty terrible at night, or day to day. You can have really bad fatigue days. So I think it's really challenging for patients to answer those surveys. And it's really hard for clinicians to understand what those surveys are really saying about a person's fatigue in their daily life. I do think that there is a movement towards assessing fatigue in daily life that could be incorporated into clinical care. I think that there's a lot of really real challenges to that, and they're mostly to do with the healthcare systems, what they allow sort of into their healthcare, their medical record systems. So it's really problems that could be overcome. I think one of the things I do want to address is that people assume that that it's a lot of burden for people to provide their fatigue ratings throughout the day, and it is a little bit. You're asking people maybe to report multiple 3-4 times a day, but people tend to like it because it really better reflects what they're experiencing. So I'm hoping we can overcome some of these technological issues so that clinicians can have a better view of what's going on with their patient. And I think, in the absence of being able to assess in real time fatigue, just asking about variability might be a first step.
Well, Dr. Plow, if fatigue is a moving target that fluctuates, perhaps even hourly, how do we design physical rehabilitation and energy conservation protocols that are flexible enough to adapt to a patient's real-time energy level on any given afternoon?
That is the million-dollar question. Like, figuring how to personalize these treatments. Right? That was one of the things I was trying to harp at in the lecture today, was thinking about how we better personalize these interventions to someone's fatigue throughout the entire day. And that's where I think EMA has a lot of benefits, because we can start to think about different trajectories of fatigue over the day and perhaps tailor our energy management strategies to those different trajectories of fatigue throughout the day. We're not quite there yet, but I think that's an important direction to go. And I think EMA can help solve that answer a little bit. I also just wanted to add that we recently did a study where we randomized people, a select group of people, to do the EMAs and just fill out the self-report measures. And what we noticed when people were randomized to the EMA, it didn't impact their other aspects of their life. Like, one of the concerns is, well, if you ask about fatigue all day long, is it going to increase their fatigue level? You ask about their depression, all day long, are they going to get more depressed? And we didn't see that. Those people randomized to the EMA group had, same amount or very similar aspects of fatigue, depression with these trait-based measures of fatigue. So we didn't see very much difference with the EMA. So the EMA, simply asking the EMA, doesn't necessarily influence what their fatigue levels are.
Dr. Kratz, you and your colleagues developed MyMSToolkit, and I remember talking to you about this in the very early days of this podcast, as a matter of fact. You created it to provide evidence-based, plain language, cognitive behavioral strategies directly to patients. What are the primary barriers to getting these digital self-management tools into the hands of patients early in their diagnosis? And how can clinicians better integrate a resource like this into their standard discharge or standard care plans?
Thanks for this question. Yeah, the MSToolkit has been around for a while, and actually we just got some funding to do some further development, including some additional information specifically for people with progressive MS, which wasn't a focus of the original iteration of MSToolkit. I think one of the problems with getting it into the hands of people early in the diagnosis, when I think it would be most helpful, is that I'm a researcher at a university. I don't have a marketing team. I'm not a pharmaceutical company with a marketing team. So a lot of it is just trying to get the word out through like the MS Society, through word of mouth. What I do see is that the clinicians that I have connections with are using it. The other thing is, I have a responsibility to improve the MSToolkit and make it more accessible and more interesting and more usable. And so I'm interested in constantly trying to improve it and make it something that people are going to want to use and refer their friends and family and their community to. So I think there's a lot of potential barriers. I love a marketing firm, but that's probably not going to happen. So doing the best I can with the resources I have.
Well, I hope everybody just heard that word of mouth and hopefully checks out my MSToolkit, right? Dr. Plow, when we look at digital health platforms and remote coaching, symptom management, how do we ensure these kinds of tools remain engaging and accessible for individuals who may face significant cognitive fatigue or manual dexterity challenges?
That's always a challenge, and I think you have to use a combination of strategies that Dr. Kratz may be able to speak to this a little bit more than I can. But, having multimedia approaches where you're having videos and you're having text and you're having visual, and so you're having different methods for people to learn the material. And there's also some self-tailoring. So encouraging that self-tailoring, right? Not everyone may be interested in cognitive fatigue, for example, but they may be more interested in physical activity or the physical aspects of fatigue. And so thinking about how you can help people self-tailor that to their own. They can click on the links that are most interesting.
You know, I always find it unfortunate to have to talk about fatigue because it affects so many people, and it can, as I said when I introduced this segment, it stops people from engaging in so many areas of their lives, right? And I think what's perhaps a little more unfortunate than that is the fact that there isn't an FDA-approved medication specifically indicated for MS-related fatigue. So given what I can only call a massive unmet need, what's the core message would you hope the neurologists, nurses, therapists that just attended your presentation take back to their clinics next week?
Well, I brought this up in the lecture of how, as a rehab person, I really think the intervention for fatigue needs to be both person-centered and tailored and multidisciplinary. So I think, there's no silver bullet for fatigue for most people. So, really considering all the resources. If you're a neurologist, thinking outside of your neurology clinic, if you don't have PTs, OTs, psychologists embedded within it, how can you engage them and maybe some of your PM&R clinician colleagues to better address fatigue from all of the different contributors of fatigue in MS?
And Dr. Plow, same question.
Really thinking about the referral aspects of this. I think there's a misconception, plug out to occupational therapists, that they only do hand therapy, right? But occupational therapists are also experts in managing fatigue, and so are psychologists. So I think it's really important to recognize the allied healthcare and what they can do in terms of managing fatigue. And so having that referral system in place and supporting that, and if they don't have that infrastructure in that place, thinking about this telehealth approaches that are popping up all over the place now.
Well, Dr. Plow, Dr. Kratz, I want to thank both of you for everything you do to improve quality of life for people who are living with MS. Thanks so much for talking with me today.